Morning. We're starting. Last lecture. Hello. Okay, healthcare policy. What is this? Come on, y'all been in class. What are we talking about with healthcare policy? Thank you. Can I give you the mic so you can hear JP on there? Okay, so it's healthcare, it's organizations, how things are done. Insurance plans, things like this. In the 70s and 80s, insurance companies pretty much got together and came up with a plan to give us healthcare organizations for the providers. So basically, it was a system. In the old days, you went to the doctor, you paid $50 for the office visit. You went home, you filled out a United Healthcare form and sent it in and showed them your receipt, and then they sent you 80% of your money back. Okay, you want an 80-20 indemnity plan is what it was called. And so that's the only type of insurance there was. So in the 70s through the 90s, the insurance companies started to change how they did business, and they formed these healthcare organizations. Okay? So you can go to an office, to clinics, to outpatients, whatever it is in healthcare, this is what is started to happen. So blanket coverage is the coverage that is just all over. It's not, it's socialized medicine, okay? Basically, it's a single payer. It's government, okay? In the United States, we have a patchwork. We have many different private mix, government, all different types of ways that providers get paid, basically. So do any of these names look familiar? These are all the different insurance companies that are out there. Coventry, Blue Cross, Humana, United, all of these are out there, and these are the different ones, different types. And this is just a handful. This isn't what really is around. There are a lot out there. So this is kind of a map that shows you the different countries that have blanket coverage, or coverage across, that cover everybody, socialized. Russia, England, Canada. A lot of countries have gone that way. And as you go through and you work on your master's in higher education, you'll see that a lot of these countries give better health care than the United States. A lot of them don't, but a lot of them do. So it's a mixed bag. What works better? It depends on where you are, okay? So healthcare access. What are the finite resources that I'm talking about here versus infinite requests? What do you think finite resources means? What's the resource that drives the world? Money. That's the finite resource. That's what the insurance companies dole out, right? That's what they do, okay? The infinite request is the health care we need. We're always you're sick. You need to be taken care of. So you have insured, which are most people, and the uninsured. Most Americans have insurance, and it's usually private insurance. It's usually covered by Blue Cross, Blue Shield, these different carriers. Public insurance are your government-sponsored, your Medicare, Medicaid, lot chips, those different public-driven insurance plans. So what are some of the mechanisms that are out there? You have private-based insurance, which are employer-based. 56% of Americans have employer-based. How many people have employer-based insurance? Okay. How many people have individually purchased insurance? Anybody? Individuals? Okay. What's the difference between an individual and an employer-based? Employers pay part of it. What else? What's the big deal with an employer-based? It's a what type of policy? Group. So a group, say 100 people are in the group, it amortizes the expenses over 100 people. So is a dialysis patient, does it cost money for dialysis? Is it expensive? So when they got insurance, it cost a lot. There's a little girl that I know who wants to become a nun, okay? She wants to go into the convent. So she went and she talked to the nuns, and they said, yeah, we'll take you, but you're going to have to, she's a diabetic and she has a pump. You know how much it costs a year to do that pump, to maintain that pump and get the insulin and everything? Anybody got a clue? How much? Close. 25 plus 5, 30,000 a year for that pump that the insurance company's paying for. Now, she's in her early 20s. She's still on her family insurance plan. But when she goes to the convent to study to be a nun, she's not going to have insurance. So the Mother Superior said, you got to pay, you got to put that money in we don't have the money to pay for it either. So she's got to raise $30,000 because when she goes into convent, she loses her insurance with her parents. And when she becomes a nun, she gets insurance, but that's like 2 years to become a nun, I think. You can, but she, once again, she will, once she moves out of the house and goes into this type of thing, and I don't understand that either, but that's not happening. It's like she's emancipated or something. The insurance company, you got to read the fine print, right? Well, let me just say, the devil's... Right. Right. Right, it might be, but I'll tell you this, that I'm a case manager, okay? I've had people who have, the son's married and the daughter-in-law, the daughter is covered by her parents, but they're married, and they got sick. And the insurance company found out and didn't pay a penny because they shouldn't have done that. They shouldn't have been on the parents' insurance because they were now independent. Okay, so what does independence mean? Going to school, living in a dorm, living in an apartment, coming home. You're not independent. But if you're out there working and been on your own and everything, and the insurance company comes out and finds it, they're not going to pay. Because it violates the policy. Okay? It says, and there'll be a clause in there about how it goes. So probably, like y'all are saying, there's something that she has to sign saying she's leaving her family and she's going to be in the convent, and that makes that clause kick in. And so the devil's in the detail, right? All right, public health is about 21%, okay? And that's your Medicare, Medicaid, lot chips for the kids here, and then the VA. The VA is a big insurer because of the people who have been in the service. Okay, so here's your little pie chart. And you can see most people are employer-based. There's Medicare, Medicaid, those types of things. But you look at this big piece here, this uninsured piece. Now that 17.7% has dropped, okay, with Obamacare. So it's probably more in the 10% range now, I think I've read. I think this was done in 2013. So since Obamacare has been around, we've gotten more of these uninsured captured into policies and all. So that's shrinking. So that's a good thing. That's a 2012 graph. So we're getting more people who are being covered. Where does Obamacare fall in this pie? Is it a private employer, Medicaid? Some of them are, but some of them aren't. okay? You got to qualify for Medicaid. Medicaid is the Bayou plans and things like this. But if you don't fall in this, you see this, what is this? This is the federal poverty level. You don't fall into Medicaid. So there's private and there is public. So there's some Obamacare in here, in the Medicaid other, and then there's some over here. So it depends on how much money you make to be able to get that. Okay, so this is just pretty much the same thing we said before. Managed healthcare organizations are basically HMOs and PPOs. Do y'all understand what that means? Who doesn't understand a HMO and a PPO? Anybody? Okay. So we're going to see what that means.
Today's question, what are PPOs and HMOs? The simple answer is, they're different types of plans for different types of people. Let's say Gary needs health insurance. If he selects an HMO, or Health Maintenance Organization, he'll get greater value in his care because his insurance company has negotiated discounts with hospitals and doctors in his area. He may end up paying lower premiums every month, but his doctor and hospital options are more limited. He'll also have to stay within the network to receive coverage. Gary must also choose a primary care physician who will help manage his health care for him. In the interest of efficiency, HMOs leave many of the larger decisions, like surgical procedures, to the healthcare professional instead of Gary making the decision himself. With a PPO, or Preferred Provider Organization, Gary assumes more responsibility for his healthcare decisions, but he pays more for that right. If Gary has a PPO, he can choose from a larger network of physicians. Unlike an HMO patient, Gary can go out of network if he wants, but he may pay more if he does. A PPO gives Gary a wider variety of treatment options, and he doesn't have to designate a primary care physician. To sum it up, HMOs offer smaller premiums but more restrictions. PPOs cost a little more and encourage you to stay within a network, but give you more options than an HMO. So now you know. Until next time, stay smart and stay healthy.
And Bayou Manor. Okay, so here are your differences. Big thing is premiums. All right, so HMOs are going to be less money than the PPOs, but you're going to have not as many choices, right? What do you have to do in an HMO? Where do you go first? Primary care, to a gatekeeper, okay? Whereas with the PPO, if I decide I want to see a dermatologist, I just go see a dermatologist. I want to go see, somebody, for my heart. I go see a cardiologist, right? Whereas with the HMO, I got to go through the gatekeeper. They have to give me a referral to go to those people, all right? So you need a primary care. Over here you don't. You got to stay in network. What does that mean? What's the network mean? Yeah, there'll be contracts with certain hospitals, with certain groups of things, so you got to stay in the network. On a HMO, if you go out of the network, you get zero. They don't cover you at all. Where the PPO, you can go out of the network, but you're going to pay a higher premium. And depending on how your policy is structured, it may be 80-20, 50-50. So if you go out of the network and you're in a 50-50 plan and it's a $1,000 bill, the insurance company is going to pay $500, you're going to pay $500. But you have that option. So if you don't like Ochsner and you want to go to East Jefferson, and East Jefferson's out of the plan, you can go, but you have to pay that out of pocket that you might not pay. Okay? The negotiated discounts, what's the negotiated discount mean?
Just discounted prices that you pay.
Right.
Say we can offer you a certain number of patients, right? And say, okay, so then you get this much off.
Well, that's how the negotiated discount comes up, okay? So basically, my wife went in for her checkup before she had her surgery, and there was a $300 office visit for the doctor to feel her shoulder before he did the surgery. I got the thing yesterday from Blue Cross, you know, the little thing that this is not a bill, you know. It says $300. It has been discounted $248. We sent your physician $52. What's up with that? That's the negotiated discount that was worked out between the provider and the insurance company for sending the patient. So the insurance company goes to a provider and says, you know, I'm going to send you a lot of patients. You become an HMO doc for us, we're going to send you a bunch of people. We're Blue Cross. We got a lot of people, and they're going to have to come to you. So the doc says, well, if you can fill up my office, I can offer it to you for this price. Now, how many people do not have insurance? Raise your hand. Go ahead. Okay. So if you got that $300 bill, would you have to pay it? Well, yeah. But is that fair? No. No. Because they've inflated their prices. Everybody has because of the environment we're in. Okay? So as an uninsured person, you go to that physician and talk to them. And you negotiate, just like the insurance companies. They will come off of their, I don't have insurance. I can't afford $300, but I want to see Dr. Pete. Okay, you know, can you afford $50? $2? Yeah, I can give you that. So, and they will. They'll negotiate. Same thing if you go in the hospital and you don't have insurance, okay? Or you have a high deductible or something. They know that that's going to happen. You go in and you negotiate with them and say, you know, hey, you charged me $10,000 for this procedure. I don't have that much money. Well, do you have $2,000? Probably it's in that 80% range. That's what they're going to get from the insurance company. So they will negotiate. But a lot of people were like you. It says, well, yeah, I guess I got to pay it. That's how much they charge. It's inflated. So be aware of these things, especially when you have problems that they'll always negotiate something. So all you got to do is go in and talk. And then it's your decisions, right? Who's making your decision with your HMO? You or the doctor? The doctor, the primary care doctor. With the health care decisions on a PPO, we make our own decisions. Where we want to go, who we want to see, what we want to do. Okay, so what about these uninsured guys? What's going on, okay? You got Medicare, you got Medicaid, you got VA, you got all of these other things, but there's still people who fall between the cracks. What happens when that homeless person shows up at UMC? Got to treat him. So he comes in, he's diabetic, his foot's falling off, we put him on Vanc, we put him on isolation, we do all this stuff. Who's paying for that? What happens is case management goes in there and gets them to fill out an application for Medicare, Medicaid, for an Obamacare, because a lot of people are not homeless, but they don't have enough money to cover them. That hospital then submits that application into the proper, insurance plans and all. 3 months later, an insurance policy is issued because under Obamacare, you have to offer insurance. You can't, pre-existing conditions are no longer there. You have to offer insurance. So they have to cover this patient. They just didn't know how to apply 9 times out of 10. So that hospital now, 90 days out, can resubmit the bill back to the insurance company and they'll get paid. Well, but you at least get paid now. Before Obamacare, you didn't. You got 0. Okay? So that's where we're capturing that 17% is down to 10 because you got people going in and they're getting these things filled out now. That depends on if, well, some people are, it's subsidized, right? It's subsidized, okay? But it's still, you got people who are paying full boat and have Obamacare, okay? But you do have some that are being fully subsidized. You're correct, okay? So that's one of the fallacies of Obamacare. 3 or 4 years ago is when it went into full-blown effect, right? So what's happening now 3 or 4 years later that they're trying to fix? What is happening to the premiums? They're going up, okay? They're going up. And why are they going up? Who got insured first? The what? What kind? The unhealthy people, the people who went to the hospital. The 10% that's less for like you and I, they're healthy. That's what the insurance company wants, right? When I said I got 100 people in my group, I got 10 people who are dialysis patients, that dialysis group is amortized out over 100 people, so I can keep my premium down, right? Because I got 90 people in this group, that's good. What if I had 10% dialysis, 20% diabetics, 30% COPD? What's my premiums going to do? Go up and up and up. So and this was predicted, they said this would happen. So until we capture those healthy 10% of that population and start getting the money into that, but as you said, if it's subsidized, it's still taxable, right? The taxpayers are paying. And what was the teeth in Obamacare? The teeth. What was the teeth? What did they do if you didn't have Obamacare? Penalize. How could they penalize you? So that guy under Claiborne Bridge over there was penalized. So it was stupid, right? I mean, it was crazy. I mean, come on now, But it got through Congress. So that's the yin and the yang these guys are trying to figure out politically with these systems. Okay. So so numbers are a big deal. So we kind of went through Obamacare, hit on that. Affordable Care Act, same thing. So healthcare organizations, okay, that's the big thing. That's the buzzword you hear, that they're out there now. And they all have, there's over 500,000 of these things. They're anything, okay? They have a unique mission, financial classification, unique ownership. But their common purpose is healthcare delivery. So a healthcare organization is somebody who gives walkers, someone who gives oxygen. It could be a doctor. It could be an LTAC, a SNF unit. Could be anything out there. Doctor's offices, hospice services, daycare centers. Many, many different levels of healthcare, okay? So the level of care is a big deal, okay? What's the highest level of care that a patient can get? Acute. What's the, is a skilled nursing unit is where on the scale? Is that below acute? Because I said it was the highest, so I gave that away, right? So skilled nursing and then an LTAC, a long term, is below that. Why is that? Why is it less? Why is that level of care low? What do we mean by level of care?
What they're able to do.
Who's able to do?
Hospital, like they have an MRI, they have a CAT scan, they have a neurosurgeon. What you mean?
Hospital or facility, right? Because a SNF unit may not be in a hospital. I mean, you may have Pete Keller's SNF unit on Rosecrest Lane in River Ridge. I could have 5 beds in my house. Skilled nursing. Skilled nursing. So it doesn't have to be affiliated with, but it is the amount of, but you're right, you're going down the right path, is that when I'm in the hospital and I'm getting 21 days of IV antibiotics, does the doctor have to see me every day? But if I'm in the hospital, they do, because I'm in an acute setting. That's what is mandated by DHH and Joint Commission. If I move you from the hospital to Pete Keller's SNF unit on Rosecrest Lane in River Ridge, the doctor may not have to come but once a week, or if needed. So services are less. You get less services as you drop down levels of care. Okay? But I mean, a long-term and on LTAC, you can have vented patients. You can have patients on pressors. You can have patients on IV things. It's a higher level of care than a skilled nursing unit. So the nurses there are going to be taking care of more intense patients. Whereas a skilled nursing unit, you're ambulatory or you're just on IVs or whatever. So as you drop down level of care, does it cost less and less and less? Yes. Well, if a doctor only comes once a week, right? So the insurance companies benefit, right, by moving you to a lower level of care. So a case manager, which I do, we go in and the insurance company says, you got 2 days, Pete. Get them fixed and get them out. That's all the doctor's got. So we got to fix them and then we got to move them on, okay? And you got to go through that. I know we've seen situations at the hospital, that we are trying to place patients in a lower level of care. They're just sitting around the hospital, wandering around, going outside, walking, doing stuff. They can't be placed, but they can't go home. They don't have insurance or something. So the insurance companies say you got to step it down. So they will give you a certain amount of days. That case manager either has to show that that patient's sicker on the second or third day and needs to stay in the hospital a few more days to get well, or that hospital's not going to get paid for that day or 2 or 3 that patient stays there. They said you're only good for these amount of days, okay? So we got to step them down. And then they'll say, okay, we're going to put you in a SNF unit. We're going to put you over here for 21 days. They have IV antibiotics. At the end of 21 days, you got to DD Mao. You got to go. Okay, so that's the level of care. Settings, inpatient and outpatient. Is it more expensive in or out? Absolutely, right? So my wife had her surgery 1 Friday ago. She went in, we went in at 7, by 2 or 3 we were home. Her shoulder was fixed, rotator cuff. My hernia surgery, I went in at 10, I was home at 2. Put a hole in my belly button and 2 down here and buttoned me up down there. Fixed it. 4 hours and I was home. So procedures and the way you do surgeries and everything. How long do you stay when you have a baby now, ladies? 2 days, maybe. More than likely you're in and out and, right, right. I mean, if it's no complications, they're not going to keep you, okay? So settings. Financial, what's profit mean? Y'all know profit. They're making money. What's nonprofit? Do what? So what is it? No money or all the profits go back into it? Huh? That one. Which is that one?
They're just paying like they're not making any additional money.
Well, what if I tell you that Ochsner is a nonprofit system? Yes, that is true. But it's correct. The profit is put back into the system. So nonprofit means that you're making money, but it's going back into the system. Why can Ochsner have 72 facilities now? Because they're making money and they're buying up things. Okay? So nonprofit means you put the money back in. Public versus private, it's pretty. Touro was private, right? Touro Hospital, Children's Hospital, those were private. East Jefferson, West Jefferson, Charity, those were public. They're not anymore. They're run by systems now. But you have different things. So historically, it was religious, it was service groups. You had a lot of trust. There was less attention paid to profit. Now, what drives the world? Money. Okay, the finite resource. So you got corporate change. You got things that are out there. Tulane Hospital is owned by Tenet. Tenet is a for-profit system. They have 600 hospitals. So where does the money go for the profit that Tulane makes? Back to the investors. They pay dividends because it's traded on the New York Stock Exchange, Tenet. Okay, so regulatory agencies. Regulatory and accreditation, we're both looking at safety and quality. Look at this, nonprofit and not-profit. What's that mean? Just one letter. We know what nonprofit is now, right? You put the money back into the organization. What's not-profit mean? They work for free. It's at a cost. What does it cost that accreditation agency? Joint Commission is accreditation agency. When they go to accredit main campus, Ochsner main campus, that's a big campus, right? So they look at it and they say, we need 10 people to accredit your facility. That's going to cost you $150,000. That's their cost to do the survey and to do your report and give it back to you and to accredit you. Whereas if they go to Luling, where I work, where we have 50 beds, and when we get accredited, they come in and they say, we're sending 2 auditors. It's $50,000. So it's based upon what the needs are for that accreditation process. Okay? These are government run, so who is this in Louisiana? Who's regulatory here? CDC? Is that what I heard? DHH. What's DHH mean? Department of Health and Hospitals. Okay? Independently owned, these are owned, Joint Commission is independently owned. I mean, it's a company that runs its own. These guys establish rules and regulations. These guys set standards. These standards cannot be lower than the rules and regulations. They have to be higher. Does that make sense? Okay. And then you're mandatory, you got to participate. This is voluntary. Equal or higher. Okay? So, when these guys come in and they find 10 or 15 things wrong at your facility, what do they have the power to do? Shut you down. When these guys come in and find 10 or 15 things wrong, what do? They don't fine you. No, they don't take your deemed status away. What do? They give you 90 to 100 days to fix it. So if I have an option, if I'm Pete Keller's LTAC on Rosecrest Lane, who do I want coming to see if I'm up to snuff? Someone who's going to keep me open and give me an opportunity to fix the things that are wrong. So most people go through accreditation processes. Now, if I fail Joint Commission and 90 days later I fail it again, guess who's coming to visit me? DHH. They're going to come behind them and then they're going to shut me down. So accreditation and regulatory, understand those things. Federal agencies, these are pretty much Department of Health and Human Services up there. CMS, y'all know about. CDC, that's the Ebola people, right, and infectious disease. Food and Drug Administration, what do? Food and drugs, Mr. Keller, that's what it says. Food and drugs. Can't you read? So they're worried about getting your medications and things done. Who does OSHA look at? What area? Employees or workforce or like plants and things like that. So OSHA can come into a hospital and say, we deem this operating room unsafe. You don't have enough ventilation. They're usually mechanical things and like they don't have hot water in the bathrooms here. They could shut this building down. I know. Okay. But we're not going to do that. Joint Commissions, Accreditation Agency, there's others. So nursing homes, SNF units, things like that. They have other agencies besides Joint Commission that can accredit them. Okay? Hospice companies. You don't have to go through Joint Commission. Joint Commission is like the big boy. Okay? So if I have a freestanding unit on Rosecrest Lane, I can call the SNF Association and say, who's accrediting SNF units? I want them to come out here and accredit me. If I'm attached to a hospital, I'm usually going through whoever the hospital is using. So a lot of times you'll see that there'll be facilities in there, LTAC, SNF units, hospice units, that are associated with that facility and renting, but they have to be at the same standards as that hospital, and they'll probably go through Joint Commission. Make sense? Understood? What did y'all learn? A lot. So, enjoy the rest of your lives. 36 minutes. Goodbye.